I'm Neil Ferguson. I was told I don't need to introduce myself, but I will anyhow. But I'm now Director of the School of Public Health here at Imperial College, which the newest building on the campus, which we're just about to move into in about a month's time, is literally just outside. We'll have 600 or so of us in there. The school is about 650 staff and about 450 students. In total, spanning all areas of public health, with close partnerships with both Imperial College NHS Trust, but organisations across the world. My background is in infectious disease epidemiology, mathematical modelling, from everything from malaria to dengue to emerging infections and COVID, of course. I'll let the rest of the panel introduce themselves briefly, and then we'll move on to about a half-hour discussion and about a half-hour Q&A, starting with Suki.
Hi, good afternoon, everyone. Pleasure to be here for my second panel session at JAWDROP. So, as Neil said, my name is Suki Balendra, and I'm Director of Paddington Life Sciences. So, to Chi's point, a new life sciences cluster in the Paddington area around St Mary's Hospital, hosted by the NHS Trust, and we have partners like IQVIA who are here today. My background is I'm a biochemist by trade, worked in industry for a number of years, and then moved my career into clinical research, really passionate about commercial clinical trials and bringing more into the UK and London, and also making sure the trials we run are diverse and representative of the population that we serve.
Good afternoon. Russell Hope. I am one of the Deputy Directors in the UKHSA's Health Security Agency's Healthcare Associated Infection and Antimicrobial Resistance Division. My background is in microbiology, and then I moved on to sentinel surveillance and then national surveillance programs. Philip?
Good afternoon, everyone. Hope that's working. Yeah, there we go. Hello, good afternoon, everyone. My name is Philip Cruz. I'm the Country Medical Director for Moderna here in the UK. As you well know, our headquarters are based out of Boston in America. And so I'm leading the company's initiatives, be it medical affairs, dabbling a bit on R&D as well with my colleagues in the R&D organization. But I had the Science Division and Medical Affairs Division here in the UK for Moderna. My background is pediatrics.
Michele.
I'm Michele Wisniewski. I'm from DNA Electronics. I work in, I'm the Senior Director of NGS Assay Development. We're building a agnostic bacterial and fungal and AMR assay. I've been in the industry for quite some time, working on both food assays as well as like human and NIPT. And also worked at Genmark for any plex assay. So been in the industry for a while. We have a site here at Scale Space for DNA Electronics, as well as in Carlsbad, California.
Nina.
Good afternoon, everyone. I'm Nina Zhu from Imperial College. I am the research lead of Population Health and Policy in the Health Protection Research Unit funded by NIHR. So our work is very data-driven, bridging the local healthcare provider across different settings, but I also work with public health and global health agencies like WHO, especially during the pandemic. My background is I was originally an engineer in synthetic biology by training, and then I moved on to become an epidemiologist and health economist. Thank you.
Thank you very much. And we're here to talk about really the challenges and opportunities of enhancing health system resilience, particularly for acute threats like pandemics, but also for longer-term emerging threats like antimicrobial resistance. And I'll kind of kick off the discussion working through the panelists by going back to the pandemic, and clearly that highlighted some of the challenges around healthcare resilience and indeed capacity in places like the UK. How do we start to address that challenge, both in terms of those acute surge threats, but also in terms of long-term challenges to healthcare resilience, such as, for instance, antimicrobial resistance? And maybe I'll start with Nina and come towards me.
Sure, thanks, Neil. So I think from a personal experience through the pandemic, my work has been really focusing on to maintain our surveillance around drug-resistant pathogens, both in the community setting but also in the hospitals, knowing that the local laboratory capacity has been reduced or has been reshifted to be focusing on the testing around SARS-CoV-2. So my experience is really about, the biggest challenging is about, first of all, the workforce shortage, both working in clinical setting on the front line, but also in the supporting service like laboratory. And even though we are in a kind of like highly equipped environment overall, but still we are lacking this kind of surveillance power to monitor what's going on, especially in the front line. So this is when we had this kind of innovation to bring clinical data, patient data in real-time fashion to support development of decision supporting tools and to implement very rapidly. But still, I feel like the main challenge is, first of all, restricted of surveillance power, but also, meanwhile, the people like me working in the background to translate this kind of evidence into practice in a rapid fashion. So that's my personal take.
Thank you. Michele.
Bit. You know, I'm working in an industry where we're trying to build an agnostic diagnostic, and that does help in surveillance. So, I mean, I see it as a way that if we can look at just viruses and bacterial and fungal in an agnostic way, we're able to detect that immediately, and that helps in terms of pandemics and including AMRs, where we can identify it immediately and make diagnostics and treatment tests, as well as continuous surveillance. And surveillance is very important in a pandemic as well as an AMR. You know what's going on, and then you can make better decisions on treatments. And that's really our goal and where I'm working, and that's why I really love what I'm doing, because once we can make that agnostic test, it can be used in multiple ways. And immediately for helping somebody, you know, in a treatment standpoint, but also surveillance throughout the world.
That's interesting. You mentioned agnostic, that's diagnostic. I love it. Do you have a T-shirt that says that? No.
I should get that, yes.
Well, borrowing on that very, very clever phrase, I think for us it's more of the platform that can reform. I mean, as you all know, Moderna's pretty much put forth in the limelight with the pandemic because we were building on a platform technology. And this is the mRNA science that we build our, initially medicines that were our idea, but vaccines is based upon. And that, I think, is a testament of the agility of this platform, where you can pivot into something that is of public health need, of a public health emergency. And that's where, I think more than that, the story that should be the banner headline for the pandemic is everyone really banded together, worked on one specific project. Everyone, the scientists, dropped what they're doing and just worked on COVID. And everything really was on that spirit of collaboration. I mean, look at our regulatory authorities. They were really kind of like streamlining their processes. And I would like to correct any misconception. Nothing was shortcutted, if I would say so. Everything was streamlined because everybody was working on COVID. And that afforded really an unprecedented scale of clinical development. When otherwise, during my previous company, where we would have a vaccine in development through R&D, getting it into job within 10, 15 years. And the longest that I've worked on was on 30 years for a vaccine against malaria. That time in this COVID pandemic. And thankfully, because also there's a lot of pieces that fell into place, we got a vaccine in 11 months. And so that, I think, is the story there, that really, if we get all together, banded in one room probably, and you know, all our minds and hearts going into something, we can achieve more.
It's certainly difficult to react to a situation if you don't have the information to hand. So our surveillance systems are essential for our success. And we have some very robust data systems in development and in operation in the UK. So our routine microbiological data flows into national systems and can be easily interrogated. So you can find a susceptibility result from a patient whose isolate has been processed by a routine laboratory lab within a couple of days of that occurring. And that's not just in England, that's across the UK. So each of the different nations of the UK has that capability. And so we need to keep bolstering that resource, and that's just the microbiological data. To get a fuller picture, you need to be able to link to other data that's available. So things like, for instance, patient information systems to tell you where and when a isolate was sampled, for example. And so via data linkage with these sort of systems and data, for instance, patient prescribing, you can get this much more holistic view. The pandemic also demonstrated the power of whole genome sequencing as well to identify variants. And on the AMR side, that's something we're moving our reference labs more and more over to. So you get as granular typing data as possible, but also you're getting identification of specific resistance mechanisms. And importantly, for resistance, when you start looking into particularly the gram-negatives, then identification of the mobile genetic elements that those resistance mechanisms are on is important. So moving to sort of like long-read sequencing lets us start to look at the plasmids as well and help identify when you may have an outbreak caused by multiple different species, but a mobile genetic element that's shared between them. In terms of early warning, then it's important for us to look at resistance problems from a One Health perspective, so developing One Health surveillance mechanisms and looking at things like wastewater surveillance and natural water surveillance will help us get those sort of like early warning signals.
So my perspective from the pandemic was I was running the COVID vaccine trials on behalf of NIHR in Northwest London. And to Philip's point about collaboration, that was the way that we delivered those vaccine trials. So very early on, we formed a collaboration between the clinical research facility here at Hammersmith, along with Chelsea and Westminster's clinical research facility and the CRF at Northwick Park Hospital. And that was really the cornerstone in which we delivered those trials, along with primary care and NIHR. And it's this collaborative working both at an operational level, at a clinical level, that allowed us to really deliver those trials at scale and pace. And government played a huge role in that with the vaccines task force. You know, there was very clear direction in terms of the priority of our trials. And for someone that's been in the clinical trials game for a very long time, it was hugely rewarding to be involved in that process. You know, you talk about adaptive trial design. You were living and breathing that kind of process. Standard of care was changing every day, and we were adapting our trials to suit that standard of care. So it was a hugely exciting time to be involved in that process. But what we've done in Northwest London is really bottled that formula, and we've kept that collaboration going for all other disease areas. So we're really learning from the pandemic and applying it now.
Thanks. And I mean, some of the lessons I've just heard the panel say, I mean, really around kind of platforms and systems, both data systems and technical systems. Looking forward, I'm just interested in how you feel what some of the still outstanding challenges, and maybe focus on two areas, how the challenges of ensuring resilience and, for that matter, health equity play out both at a local, national and a global scale, but also how do we fund this in a sustainable way? We're just out of the pandemic. Clearly, it's still a priority. Sally Davis highlighted the importance of the AMR O'Neill review, investigated and proposed different models for financing. How do we, though, keep that going next 5, 10, 20, 30 years? And maybe I'll go in the other order. Suki.
So Imperial College and Imperial Trust are part of a very exciting new initiative to create a Fleming Centre in Paddington near St Mary's Hospital. So this centre will be hopefully in time for the 100-year anniversary for the discovery of penicillin by Fleming. And this centre that we will create will be the epicentre to really develop the research and innovation around AMR, and not just have the scientists, the academics, the clinicians in that institute, but also the policymakers, the civil servants being part of that development. So we are adapting policy as we're developing the science. Also at the heart of this institute will be the public. So the centre will be designed around a very close relationship with our public and really informing behaviour changes. So we heard in the last panel session about the choice between the apple and the donut. How do you change behaviours around AMR? It's really keen that the patients and public are all part of that process. And I'm sure you would have heard in the press that Prince William is our patron for that initiative, and we've received £5 million from the Treasury. So we are now actively fundraising to create that institute by 2028.
In terms of building resilience, one of the key issues with antibiotics is that we're running out of them. So we need strategies to try and stimulate development of that antibiotic pipeline and help support companies bringing those products to the market. And one of the problems with antibiotic development is that it takes a while to realise a profit. So, for instance, if you're bringing a new antibiotic to the market, it can be 23 years before you actually start to see any profit, combined with the fact that when you bring a new antibiotic online, people are going to want to save it to try and prevent resistance being selected for. So we needed to disrupt that kind of economic model. And something that the UK has been trialling is a subscription model. So if you look in the literature, you can sometimes just see it described as the Netflix model for antibiotics. And so this was trialled over the last few years with ceftazidime avibactam and cefridicol, and it has been very successful. And from January 2025, we're going to see that start to be rolled out for more antibiotics. So that is helping us bring antibiotics to the market. The other thing you need for resilience is to have a clear strategy about how you're going to try and deal with resistance. And the UK government has a long-term objective to try and get a handle on antibiotic resistance. So we have a 20-year vision to try and do this, so by 2040. And within this, there are national action plans for antimicrobial resistance. And this isn't just something that we do in the UK, this is something that the WHO recommend. So we're just coming to the end of our current national action plan, and for the last year or so we've been developing how the next one will look, so the one to run from 2024 to 29. It's an iterative program, so it's building on the achievements and developments in the last National Action Plan. So you're going to see more of the same, and there will be a focus on interventions, but there's also some work looking at rapid diagnostics, looking at vaccines and alternatives to antibiotics like phage therapy, for example, as well.
Full disclosure, is my microphone working?
I think so, yeah.
Full disclosure, I had an apple flavored donut earlier. But just on the topic at hand, when you look at AMR, actually it's also being called the silent pandemic. And so I think really where we need to realize is the impact of AMR and what it has and what we can do about it. Within Moderna, what we're really interested in is on the direct and indirect approach to addressing AMR. Direct, of course, what we envision is you prevent infection so that you don't use as much antimicrobials, antibiotics, and what have you, that can give rise to AMR. Indirectly as well, of course, you prevent infections, but also, direct to address the specific bacteria. Indirect, you prevent the infections that you use antimicrobials for, and therefore decrease the burden of such. I think that's where kind of like what we envision to use our platform would be, is now looking into bacterial infections. Because as you know, we kind of started our research and our fingerprint towards viral infections. But now we're looking into bacterial, and so that's an area of study and research that pretty much focused on as well. So again, it's decreasing the burden of use of antimicrobials. But of course, I think really what we see right now globally, because I'd like to also reiterate the global impact of AMR, because even though if one country is very rational in terms of its antibiotic prescription, if we don't live in a world where there's no contact in between and across borders, and so the transmission of bacteria which are resistant can go across geographies, and therefore it can't be an initiative of one country. And if you look at really the picture out there, there are plans actually with these countries, but are they being implemented? That's another topic for another jaw drop. But in terms of really how this needs to be, it is an ongoing discussion, but it's a discussion that needs really to happen 30 years ago, and the next best time to do it is now.
Yeah, I agree with you. There's when I look at it, we look at it from the perspective of trying to get a test right away so that we can change the way somebody is being diagnosed and what they can change in terms of what they're using for an antibiotic. But at the same time, it's really important to prevent. It's important to prevent in the perspective of our food, our environments, and other areas that we need to be testing heavily. And countries do it differently, and countries also don't always look at AMRs and resistance when we come to the food industry and come to the water industry. We look mostly at, we have a E. coli, we have a salmonella. So it's important that we have it in not just in testing of humans when we already are in a place where we have an infection, now we have to quickly change an antibiotic. It's better to prevent it from happening by keeping it out of our food supply, keeping it out of areas where we can actually get it. So I think, again, a diagnostics that enforcing certain industries to change practice and how they use antibiotics, or also how they have to test for them, would be very important in bringing down this, everyone getting different forms of antibiotic resistance from different areas. So from my perspective, there's a way we can diagnose it, but we can diagnose it to prevent it from happening before we get it.
So I want to actually echo on what has been mentioned by the panel before, and bring it down to what is the implication to a lower level, as what does that mean for healthcare facilities? Because we talked about behavioral change, we talked about data linkage, building economic case. For example, like we know we have the Jim O'Neill report. We also have the Graham study looking at mortality and economic burden associated with antimicrobial resistance at global level. So we all know that at societal level, it costs a lot. It costs humankind a lot. But I feel like it's a concept that is kind of far, or you feel distant. But what does that mean in terms of you being within a research institute, within a healthcare organization, or being someone on the front line? I think it's critically important that we must bring it down to an organizational level to make the healthcare management to understand what does that mean for your organization. If you adopt a new point of care diagnostic, or you have the vaccination rollout, what does that mean? But not just focusing on the hospital, but also the community settings, because we know there's a lot of economic burden associated with AMR that's currently not being captured anywhere because it's in the community. When patients got infected by drug-resistant infection, they were treated in the community, they went back to the community, and this kind of like productivity loss or economic burden is not captured anywhere. So I think I'm personally confident to say that to date, we still do not have a full picture of what exactly AMR cost humankind as a societal level. So we can't just go to the biggest level because it's an idea quite distant for everyone to feel, no matter you're a public or a patient. So I think we should kind of like break it down to different levels. What does it mean for primary care provider? What does it mean for hospital management? What does that mean for your trust or your clinical commissioning group? So from that, I think it will kind of bring it closer to everyone that working in the area. So we know that, okay, I will be more driven to change my behavior. I'm more driven to adopt new point of care diagnostics. So that's how I see the whole thing. Just to summarize, yeah.
My pediatrician voice is itching to give its thought around this, and especially I remember in terms of preventative preventing infections, because that's where you can really address the occurrence of AMR and other infections. For example, if you prevent influenza infection from happening, it's a respiratory infection that I remember. One complication of a patient that I had with influenza infection was invasive staphylococcal infection. And I also had a patient who had chickenpox and developed a group A streptococcal skin infection. And so these are the ones that we want to avoid of the superimposed bacterial infections from happening. And that's why prevention is always key, so that it doesn't give rise to these secondary infections.
Obviously, I completely agree. Prevention is certainly better than cure. And yes, I was in the steering group for the GRAM project, and I agree it's given a good first pass of the burden of antimicrobial resistance worldwide, but there are still enormous data gaps. Just in our last kind of bit of the panel discussion before we open it to questions, I'd like to come back to the issue of equity, or really inequity, and diversity and inclusion. The pandemic highlighted it's notable that we have a disproportionate representation of minority ethnic populations within the healthcare workforce. They were also disproportionately represented in terms of disease mortality and severe illness in the pandemic. And also, in many cases, there were higher levels of vaccine hesitancy and less inclusion of those groups in clinical trials in the pandemic. These are all lessons we've learned, but how do we actually go about addressing them to avoid that sort of inequity going forward? And I'll go in reverse order, starting with Nina now.
So for me, my personal answer to that is kind of like more relevant to my daily job, which is a data scientist. I feel like at the moment, like I agree with what Russ has said, we have a very robust disease surveillance system, both syndromic but also isolate or specimen-based. But meanwhile, we lack universally kind of like usable data that describe the overall condition of a patient. And that's what currently giving us challenge in terms of evaluate any intervention or technology or decision support tool or vaccination. So I think that's a first thing that we need to address before moving on to a next step. So I feel like we need to develop some sort of framework to capture the overall the condition of the patient, but also the socioeconomic status relevant to certain conditions. The comorbidity, the patient living in care homes or taking long-term medication, or apart from the ethnicity grouping, whether they are, and also deprivation index, that's something we already addressed, but there is something else we could capture to make sure that, okay, we have some sort of universally agreed framework to capture the socioeconomics and which in general well-being of a patient or a person. And so we could capture this, and then we link this kind of data with any surveillance, syndromic surveillance or specimen surveillance we have to describe the epidemiology of an infection. And then this allows us to understand better, first of all, which population is at higher risk, and second is the true effectiveness of intervention or technology. That's my answer to that.
the United States, where I'm from, they do a lot of surveillance in terms of, poverty versus, just different economic groups as well as ethnicity. And it really is dependent on where you are located in the United States. So if you're more in the southeast versus the northeast, you see a lot more poverty, you see a lot more different diseases, and you also see a difference in the way antibiotics and other things are used. I mean, since people come in so late into a disease when they're in more of a poverty state, you'll see people having to use a lot more antibiotics. So I think it's really important to have truly good, affordable health care for everybody, and also to have more availability to rural areas and different areas to be able to get the same standards of care. And I think that's what really would help in terms of getting less antibiotic resistance, having people adhere to the same policies and how you take antibiotics or how you treat diseases. That would really go a long way in improving economic issues. But beyond that, one thing that was in our country for the vaccine, we saw that people actually had to go door to door in certain areas and give the message and bring people to a place to actually get vaccinated. So that was something that was done in our country. But I think what also has to be done is a lot more messaging by the government, every government, on how we do antibiotics, how we do certain things, when to go into the doctors. That's really what will help. If you message more people will go in, more trust is there.
I think that's mirrored as well locally. I mean, you have data where you have the disparity in terms of really access to healthcare, and that's where you see incidents of AMR increasing in these communities. Those who are belong to the minority ethnic, and I'm sure Suki would talk about that in depth. But really, when you see all the parameters of public health measures, they're really down. And that's what kind of contributes to this cycle of AMR, if you will. And that's kind of what we need to address, the information piece, engaging with the community elders or those figures that they trust, coming up with languages or dialects that they would understand, not just pamphlets that of one language. And so that's kind of being the inclusive area of addressing these inequities.
So the variation we see in infections and resistance based on social deprivation isn't a particularly new issue. So we saw that variation with COVID, but we also see it with some of our more traditional healthcare associated infections, such as MRSA, for example. You also will see a variation across the country, which does follow to some extent the difference in deprivation as well. So it's definitely an area that needs to be focused on. Importantly, even though we had fantastic success at reducing MRSA bloodstream infections, for example, the variation we saw at the peak of that is still present. Now we've seen the reductions. So what we originally thought is that as we saw reductions, we would see that variation between regions with deprivation go away, but it hasn't. So clearly more focus is needed. And certainly our proposals so far for the next National Action Plan involve a lot more modelling around this, looking at deprivation, looking at ethnicity, etc., and then using that information to help structure interventions that can try and see a reduction in the variation that we see. So it will definitely be a focus of activity. From an economic point of view, it's also key to really try and capture the burden of these infections, particularly when you're talking about rapid diagnostics. Because if your diagnostic test is just trying to prevent a patient getting an antibiotic prescription, your diagnostic test has to be really cheap. But so it's the wider burden of AMR and infection that needs to be taken into account to make those rapid diagnostic tests more justifiable?
So one of the, when we were delivering the COVID vaccine trials, for example, we were quite reliant on the cohorts that we use for our recruitment. So we had the National Vaccine Registry, we had local cohorts, and that really skewed our recruitment. It made actually the trial participants less diverse because those who signed up for the registry were generally white middle-class males. So that, you know, from a personal perspective was what really pushed me to look at this agenda even more. You know, what can we do to really change the dial locally and nationally? So some of the ways that we are really pushing that through is, one, our relationship with the sponsor companies, those that are writing these protocols. Because if you have exclusion criteria with diabetes and cardiovascular disease, for example, you're cutting out huge swathes of our population. They've got no chance of getting in the trial in the first place. And often, you know, we talk about these are often sort of copy and paste jobs from previous protocols. So when we were delivering the vaccine trials, I remember our clinicians fought so hard to include patients with HIV. You know, there was no reason to exclude those patients, but they were part of the exclusion criteria. So our relationship with the sponsor companies and influencing those protocols is key. The other aspect is community engagement, which is not a short-term effort. It has to be a long, sustained effort with our community. How do we increase the awareness of research, the benefits of participating in research? How do you address the issues of mistrust within our community? You know, when our community members can't get at a healthcare appointment, they can't see their GP. I had an example just a couple of weeks ago. I was really unwell, and the GP wouldn't see me face to face, had a telephone appointment, and then said that she would prescribe me antibiotics as a precautionary measure so I could go and get the prescription. And I think that's sort of case in point. And the last bit is around the site teams, the research teams that are delivering the research. You know, do they have the space and time? Do they have the training? Are our investigators from a diverse group themselves? You know, are they offering clinical trial opportunities and equity? There are so many pieces of the puzzle, and you can't just affect change in one piece. You have to take a whole systems approach to that. And I commend companies like Moderna that are really taking this issue seriously.